good morning, good afternoon, good evening from whenever you're joining us from. Welcome to this Africa Health Business and Lumira DX webinar, Them Beyond the Pandemic. My name is Victor Mwanza from Africa Health Business. Before I hand over to the moderator of the day, I wish to make a few highlights about the session. As you can see on your screen, the session will be in English. Attendees will be on mute during the session. This session will last for 90 minutes. Feel free to post your questions in the Q&A session at any time during the session, and they'll be responded to as much as possible. To highlight the session agenda, we will have 5 panelists, a moderator, 3 speakers, and a representative from Lumira DX. Thereafter, we'll have a Q&A session, parting shots from the panelists, and finally, concluding the session. And now, let me introduce the moderator for the day. He is a visionary entrepreneur and an industry captain. He has been a groundbreaking pioneer in the metamorphosis and integration of the healthcare management in Africa. He is the chairman of Africa Health Business and president of Africa Healthcare Federation. Ladies and gentlemen, Dr. Amit Entaka.
Thank you so much. Thank you, Victor. Thank you, attendees, for spending time and joining us. This amazing panelist group that we have are going to take us through this amazing 90 minutes of engaging on the testing strategies that we've all been talking about. Of course, the pandemic has given us a huge focus on how we are testing for COVID, but what it has also brought out is how do we transform testing landscapes for several other diseases on the continent. I can see many of you are champions in the space of healthcare diagnostics. I would like to once again thank you for joining us from different parts of Africa and beyond. Let me kick off on setting the stage and invite more people on the panel. To set the stage, I've got 2 slides that I want to share with you, and thanking Lumira DX and the Africa Health Business team on putting such a wonderful webinar together. Today's webinar, which is really beyond the pandemic, is to set a firm ground on how we can get diagnostics done quicker, better, and even more in a cost-effective manner. The first slide I want to set the stage on is both NCDs and CDs are a major issue. All of us are dealing with this on a day-to-day basis, whether it's a primary healthcare clinic, a hospital, a laboratory, or any research institutions where we are trying to find out more on. NCDs are becoming a major burden. And if you look at it on these data, you have cardiovascular disease, you've got cancers, you've got all those kinds of conditions that you are all aware of on the left. And on the right, you can see that communicable diseases are still a major issue. And today, with Professor Grant Theron, who is going to give us more about the respiratory pathway, you can see it's a big burden, 32% of the 63%. Neonatal disorders, malaria, HIV, AIDS, TB, that the Global Fund continues to fight for, remain a large blue bar on what we consider major conditions. Let's go to the next slide, and I'll also set a stage on common medical tests. And if you look currently, and you try to find out the bill of the diagnostic tests being done across Africa, from primary healthcare all the way to secondary and tertiary healthcare, you will see the common tests are highlighted in yellow. And then there are the more expensive tests because you may need bigger machines or you need equipment to do those tests. But there are many simple tests that are being done, which in many cases are not being done appropriately, are not being done in the right time, and you have delayed diagnosis, and you end up with patients sometimes ending up at a hospital, either with a coma or with an advanced stage. And so prevention is better than cure and cheaper than cure. And one aspect of getting the right test at the right time in the most cost-effective manner and closer to you is going to change the health landscape in Africa. Like Peter Sands from Global Fund says, we might actually reduce our progress by a decade if we don't continue dealing with these diseases appropriately. I don't need to go through all that. You've all seen these tests. And to actually kick us off on the respiratory pathway in Africa and what the reimagining looks like, I'm extremely delighted, and I've heard a lot about Professor Theron. Today, he's joining us from South Africa. He is the Associate Professor at Stellenbosch University. Professor Theron, I am delighted to have you as a guest with this esteemed panel. Please come forward and give your address to us. Professor Theron, the floor is yours.
Thank you very much, Chair. Right, thank you. I can see my slides. I hope you can see me. I will start. So thanks everyone. It's a privilege to be invited to this talk, to give this talk. I think we are at a key once in a generation point where we have the opportunity to repurpose a lot of the tremendous efforts and accomplishments that have recently been gained with COVID in Africa, and to make something good out of that, because in some ways a lot of other diseases have suffered due to COVID taking away resources. So I'm going to walk you through some of my thoughts as someone who is a TB diagnostics researcher who is also starting to think more and more about how tuberculosis interacts with other diseases that are increasingly circulating. So I'm based in Stellenbosch University Medical Campus, which is in Cape Town, South Africa. You can see it's adjacent to this hospital in Brown, which is a very large tertiary hospital in Cape Town called Tygerberg. Next slide, please. So, you know, Cape Town is an extremely beautiful city, but next slide, please. It also has extreme levels of poverty and extreme levels of inequality, and it has one of the highest prevalences of tuberculosis in the world. Next slide, please. And when thinking about tuberculosis in South Africa, it's one of the key infectious diseases that is inherently linked to non-communicable respiratory diseases. So in other words, many patients who are treated for tuberculosis and many patients who are indeed investigated for tuberculosis often have other respiratory infectious diseases. And these can be various lower respiratory tract infections, as well as SARS-CoV-2 most recently. And importantly, many of these diseases, even when patients are appropriately treated and cured, they lead to post-treatment complications. Post-tuberculosis lung disease, for example, is a major problem where, due to the tissue damage, those people almost become lifelong respiratory cripples. And this is two sides of one coin, because we also know, for example, that patients with asthma, COPD, and other forms of non-communicable lung diseases themselves are more vulnerable to infectious agents like tuberculosis and SARS-CoV-2. So these are two categories of diseases which in some ways represent an artificial dichotomy. They are actually intrinsically linked to one another, and they both feed each other. And I think thinking about a diagnostics perspective, we really want to start adapting what are traditionally infectious diseases diagnostic pathways into our approaches for either ruling in or ruling out potential non-communicable diseases. Next slide, please. So the burden of infectious respiratory diseases is unexpectedly high in Africa. It's amongst the highest in the world. You can see that by the hotter colors in Africa. Next slide, please. Next slide as well, please. And if you see the causes of these lower respiratory tract infections, I'm now talking about things other than tuberculosis and SARS-CoV-2. But Streptococcus pneumonia, RSV, Haemophilus influenza type B, as well as influenza, are really the top causes of death in Africa. Next slide, please. And they collectively result in hundreds of millions of episodes of disease every year on the continent. And what's important is that almost half, in the case of Streptococcus pneumonia, as well as RSV, more than half of the total cases actually happen in children who are under the age of 5, as well as the other half predominantly in the elderly. So they are extremely vulnerable populations at either end of the spectrum that should be diagnostic priority groups for tests that are able to target these diseases. Next slide, please. But tuberculosis, unfortunately, still remains the biggest infectious cause of death, even compared to those infectious diseases put together. So in Africa, there were approximately 2.4 million cases of TB last year. This is all, of course, pre-COVID. Little over half of those TB cases were ever diagnosed. Almost 40% were not diagnosed. There were also over 500,000 deaths. TB incidence has been creeping downwards in the last 20 years in Africa, but it is concerningly reaching a plateau and is actually above what the 2020 target for the NTB milestones were. Next slide, please. And of course, COVID has made absolutely a mess of the control of all of these diseases. Next slide, please. And in fact, especially for TB. I think what's remarkable about this slide from the African CDC is that COVID-19 diagnostic capacity for a condition that did not exist 18 months ago has really tremendously scaled up. So not only have there obviously been tremendous numbers of COVID-19 cases on the continent, but there've also been over 60 million tests done. And I think this is a potential silver lining that other respiratory diseases could extract from some of the lessons learned due to COVID. Next slide, please. So COVID-19, it's worth pointing out, has been especially disruptive for tuberculosis. On the left, you can see the monthly TB case notification rate across 4 countries in Africa as a percentage of the cases that occurred in the first month of 2020. So in South Africa, for example, where I am based, the current number of patients diagnosed with TB is about 30% of what it was in January 2020. And those cases, it's not that they're not occurring, they are just not being diagnosed and they're not coming to the clinic. Some countries like Mozambique have successfully actually managed to strengthen their TB diagnostic program in light of COVID and are actually diagnosing more TB cases now than they were at the beginning of last year in the period before COVID. Kenya has also been badly affected, as has Namibia. Next slide, please. And critically, this is just some modeling data showing that actually due to disruptions in TB care caused by COVID-19, and now this is just focusing on South Africa as an example, but there are expected to be approximately 50,000 excess deaths due to tuberculosis as a result of disruptions to TB care caused by COVID-19. So there really is an impetus on us to recommit to strengthening the diagnosis of tuberculosis as we hopefully emerge from this COVID-19 period. Next slide, please. So when trying to reimagine the diagnostic pathway for respiratory diseases, it's helpful to think about what principles we should apply. This is really sort of a wish list. Many of these notes and concepts that I'm going to suggest now probably need prospective research to confirm their validity, but I think they do serve as a useful framework for guiding how we start to reimagine respiratory care. Next slide, please. So one of the most remarkable things about respiratory disease in Africa for me is that even though tuberculosis is the single biggest infectious respiratory pathogen in the continent, right? And there is really a massive existing continent-wide diagnostic infrastructure for testing for TB that does fairly sophisticated real-time PCR tests every year, millions and millions of them. Most of those people who are tested by those tests do not in fact have TB, right? So they come back with a negative TB result. And nevertheless, they came to the clinic, they were sick, and they had respiratory symptoms. And we don't really know what those patients who do not have TB have. Next slide, please. And the Venn diagram for how these different respiratory pathogens interact is really something that's a very open research question, right? We know, for example, that having TB increases your risk of getting SARS-CoV-2. But we don't have a good epidemiological surveillance data through Africa about what respiratory pathogens are often found in people who are investigated for TB, and which co-occur in TB, and maybe which are more frequent in people investigated for TB, but who turn out to not have TB. So really the first kind of principle that I'm going to put forward to the audience is really just the comment that really no patient with respiratory symptoms in Africa should be tested for just a single pathogen. I think that is very outdated thinking. And for example, everyone tested for TB should probably be tested for SARS-CoV-2. These are diseases that have similar causes, similar risk factors, similar presentations, and when they co-occur, it's an even more lethal combination. Next slide, please. So respiratory diagnostic pathways are completely siloed and not integrated. Next slide, please. Yes, thank you, and again. So if you look, for example, at a typical TB diagnostic algorithm that relies on GeneXpert, the most patients are going to test negative, and they are going to flow into the highlighted area of the flow diagram. Those individuals, usually nothing happens to them. Algorithms recommend that they receive empirical short-term antibiotic treatment, and a wait-and-see approach is taken. We know that in reality this is seldom done, but even when it is done, it is actually not that useful. Next slide, please. So in other words, we are already actually doing the bulk of the work in order to generate millions of negative TB test results every year in Africa. So what I am proposing here is that if a patient is TB negative, they should likely be reflexed to another test. And importantly, going back to my earlier slide, this can also help identify people who, for example, if they comprehensively test negative using common pathogen screens, they probably need care for chronic lung disease. And in Africa, the burden of non-communicable chronic lung disease is a huge unrecognized problem. So this is just an example of how integrating these different diagnostic pathways could benefit CDs as well as NCDs. Next slide, please. So another key concept when thinking about respiratory pathogens is really rethinking the who of who needs testing for respiratory disease. This is something that I think SARS-CoV-2 has brought home very well, is that a huge amount, if not the majority of transmission in some settings, actually comes from asymptomatic cases. This was one of the reasons why public mask wearing was mandated, irrespective of if you felt well or not. And to use the example of TB, but it's also true for a lot of other respiratory diseases, waiting for patients to actually have a prolonged cough for 2 weeks before they come to the clinic is something that is really quite harmful in a way, because you're saying to those patients, go out in the community and transmit disease more before we come back and treat you. And critically, it's increasingly been documented that most people with TB, just like SARS-CoV-2, actually do not have symptoms. So when they do a prevalence survey and they test everyone for TB irrespective of their symptoms, you can see from that graphic on the right, in Africa, approximately 50% of those people who come back with positive TB come back with positive TB microbiology reported never ever having experienced symptoms. So testing based on symptoms is only enough, is not enough, apologies. And waiting for people to feel sick simply means that we are never stopping the spread of disease at source. So we need to think about how we target people who are not the traditional respiratory disease suspects. Next slide, please. And critically, biomarkers are increasingly appearing to be a better way to identify and triage patients who receive respiratory pathogen testing. For example, CRP is a biomarker that has been very well characterized for a long time. And this is a protein made by the body in the liver, usually as part of an inflammatory response. And this has recently been recommended by the WHO as a potential adjunct or even an alternative to TB symptom screening, because we know symptom screening has poor sensitivity and specificity. And that's when it's done well. And most of the time, it's very vulnerable to quality of care. Symptoms, especially for things like cough duration and weight loss, are also often, unfortunately, subjective. Next slide, please. So this is a really nice study from Uganda, which shows the CRP levels on the x-axis in different types of people who have confirmed tuberculosis. And the orange line shows that very high proportions of people who are coming to health facilities have elevated CRP. And most of those individuals on this graph are tuberculosis cases. Importantly, CRP levels are also elevated in community-based patients. They're not as elevated as the very sick people who are coming to health facilities, but there nevertheless is a distinction compared to the control groups that are represented by the green. So CRP is one example in my book of a very low-hanging fruit for which commercial assays are increasingly starting to emerge, but can be used to very cost-effectively refer people on in an efficient manner for downstream molecular testing. Next slide, please. So the fourth principle I really want to put forward to you is that all people with risk factors for TB should first get a cheap CRP test before proceeding to this confirmatory test. It's important to note that CRP is just one biomarker. It's probably the best validated biomarker so far, but other biomarkers that are indicative of other conditions that put you at risk for TB, such as diabetes, also have utility. And in fact, there are policy recommendations that, for example, all people who have abnormal HbA1c levels should automatically be tested for tuberculosis. Next slide, please. So one of the most interesting and I think potentially game-changing ways of diagnosing TB that has really recently come to the fore is actually using tongue swabs. And how it works is that the tongue papillae, which are these high surface area microstructures on the tongue, almost act as a filter or a catchment device for respiratory secretions from the lung. And as those respiratory secretions from the lungs wash over the tongue biofilms trap the TB in this case, or even trap SARS-CoV-2 as demonstrated by this NEJM paper. And that is a very concentrated form of biomass that then can be easily and non-invasively sampled for diagnostic testing. And the utility of this for SARS-CoV-2 has been demonstrated in this paper. And next slide, please. And furthermore, has also been demonstrated for tuberculosis, where testing for pulmonary TB with a tongue swab, which can often be self-collected and done by a non-skilled individual, has fairly good sensitivity and specificity. So the fifth principle I want to put forward is that there is an absolute burst of new technologies for new TB tests and which target non-invasive specimen types. And these are increasingly needing to be validated. And what's important is that with specimen types such as tongue swabs, it's clear that actually that same swab can be used for multiple pathogens, such as SARS-CoV-2 and TB. Those could potentially be multiplex in a single test, or it could be in separate tests. Next slide, please. So I next want to talk about the importance of point-of-care testing solutions. So in South Africa, this is what's called a cascade of care, using TB as an example. And in South Africa, even though we are trying our hardest, we are currently only treating about 53% of the TB that occurs every year. And only about 82% of the people who have TB actually are tested for it. And then 70% of the people who have TB and are tested are actually successfully put on forward to treatment. So the key take-home message here is that at every step of the care cascade, patients are lost. And there's been research that shows that this loss at each step of the care cascade is greater and greater when diagnostic delay and turnaround time is increased. Next slide, please. And this really nice study, it's now quite a few years old, but what it does is that they surveyed the conditions across many African and Asian countries, across domains of temperature control, power, water, security, refrigeration, stock keeping, IT equipment, etc., etc. And they actually asked TB programs, are these typically present at your primary healthcare facilities where testing for many other respiratory pathogens also occurs? And you can see there's a lot of red and there's a lot of yellow in this. So next slide, please. So point of care testing solutions really need to be able to overcome many of these infrastructural limitations in primary care. Because as you can tell from this, the infrastructure is extremely weak, and any technology that can tolerate those weaknesses or sidestep them would have tremendous benefit for patients. Next slide, please. So moving on to some of the possible silver linings from COVID, SARS-CoV-2 testing capacity has scaled rapidly. As I mentioned earlier, there have been over 60 million tests in Africa in over a year. It boggles the mind to think about that we can do this many tests for something that didn't exist 2 years ago. And it already exceeds our TB testing capacity. It's doable on an annual basis. And I think now, if you go to the next slide, please, there's capacity to really pivot to other important respiratory pathogens. And the diagnostic infrastructure strengthening that occurred for SARS-CoV-2 must now be used for other tests, for other diseases, which include TB. Next slide, please. So just to recap some of the principles I put forward, I think no patient should be tested for a single pathogen alone. And then if that patient with respiratory symptoms is negative for TB, which is the most common infectious cause of death in Africa, they still should be reflexed to another test. Testing based on symptoms alone is not enough. We need risk stratified approaches and universal testing approaches. And we need the technologies to be cheap enough to make that happen. And one way of making that cheap is to do that testing, that expensive confirmatory testing, in a more cost-efficient and more rationalized way. And that can be done using triage testing, using a biomarker such as CRP, which is just probably the most mature biomarker and already has WHO guidance to support its use in the field. And critically, we need assays validated on non-invasive specimen types, and we should be able to use the same material for multiple disease conditions. Furthermore, point-of-care solutions are critically needed so that patients can get diagnosed in a single clinical encounter and avoid multiple visits, which is also associated with catastrophic patient costs. And there really is this opportunity now to leverage the SARS-CoV-2 diagnostic infrastructure for other diseases. Next slide. So distilling this down into a framework for thinking about which diagnostic tests to evaluate, this is really everything I've just spoken about in one slide. And obviously we want things here to really fall into the green quadrant, where we need tests that are point of care, useful for more than one type of test use case. In other words, they can be used to do triage or confirmatory testing. They can be useful for more than one disease. They can be not dependent on needing invasive specimen types. And critically, they can leverage the existing infrastructure. And then stuff on the right of that quadrant is really undesirable and is difficult to leverage. Next slide, please. So thinking about how best to move forward, rapid clinical evaluations and trials of promising new tests are needed. This requires a recommitment from funders to fight respiratory diseases other than SARS-CoV-2. I think national programs in Africa need to be supported to rapidly incorporate the latest global guidelines for biomarkers like CRP. As researchers, we need to do better to characterize pathogens other than TB in symptomatic individuals. And critically, diagnostic tests are not just about sensitivity and specificity. Feasibility, turnaround time, connectivity, and user-friendliness are arguably just as important. And there really is a once-in-a-generation opportunity at the moment, and I hope it does not pass, to leverage momentum from the African response to SARS-CoV-2. So with that, I thank you, and I'll be happy to take any questions.
Thank you so much, Professor Theron. We learned so much from those slides. I'm going to keep you in the panel room, and I'm sure I'm going to come to the questions when we circle around. But we learned so much. I mean, I really learned about CRP more than before, but I also learned about the tongue swab that you talked about. One of the questions that easily came quickly is about who's going to pay for this. And you say we should not, just limit it to one test. And Tanusha has asked, Tanusha Kristen, and you actually did mention that there are innovative ways and there's a burst of innovation around POC. So do stay with us on the panel room, Professor. I'm going to come back to you on some of the questions, but let me invite Dr. Paresh Dave to take the segue from here. You mentioned Kenya, and one of the laboratories that have been extremely busy to do the 60 million tests has been the Meditest, which is led by Dr. Paresh Dave. Paresh Dave is a pathologist and is a well-renowned pathologist in Kenya. And Meditest Diagnostic Services offers quite a range of tests. So Paresh, you've heard Professor. First, thank you for your time. You've heard Professor. You've also heard about the costs. And one thing that came out was point of care testing. I really want to hear your views about how do we make it more affordable? What is your view about point of care testing? And what are the concerns? And please, even before you jump into that, feel free to make your reflection points with Professor made. We have 7 minutes with you. And then, of course, I have 7 minutes with a champion from Addis Ababa. Then I'll bring you back on the panel. Paresh, welcome. Over to you.
Thanks. So let me just give a brief description of what point of care testing is for some of the people who have logged in. So point of care testing, basically, we are referring to tests which are performed where patient care is being delivered. So we are looking at a bedside scenario in the physician's office, but there are also other situations where we do point of care testing, including within the hospitals, like the emergency department, the operation theaters, the ICU, and in non-hospital settings, like nursing homes, ambulances, medical camps, and so forth. And, most of this point of care testing is exempt from regulations. So there are no regulatory authorities as far as Kenya is concerned regarding point of care testing. So virtually anybody can do this point of care testing. And we're not sure if people are trained well enough to do this kind of testing. In the US, for example, they have divided point of care testing into two groups, exempted and non-exempted, meaning that there are some point of care testing in which the chances of getting errors is minimal. So those are the kind of tests which can be readily used by various types of situations. Various types of people can use it. A good example would be monitoring blood sugars, for example. Whereas there are others which require more intense supervision, especially in hematology. If you want to do point of care testing for INRs, which is being done in some of the coagulation clinics in the West, we don't have it here yet as yet. So it all depends on the level of the tests that are being carried out. It is a useful tool because it gives you rapid results. It can give you you can make quick clinical decisions, especially in a cardiac setting, when you want to do troponin levels and make quick decisions as to what kind of patients need to be taken for angios and so forth. So there are plus points for point of care testing, and there are also negative points as well. In some instances, we need to confirm whatever results are generated from point of care testing, the sensitive tests, they have to be confirmed with the conventional laboratory methods. So again, that would add up to the cost because you need to confirm with the conventional laboratory results. The other thing is that we have quite a number of point of care testing menus here for different parameters. And the equipment that we use needs to be serviced. The people know how to use it. Is the test easy to perform? Who interprets the results? If you have abnormal results, then what is next to be done? So if you do not have staff who are qualified to interpret these results, then you will end up in a quagmire. You won't know, the patient will get more confused. So we need to set up standards. We need to know who is supposed to be doing the testing, who is going to supervise this testing, what quality control measures are being taken. Is there external quality control for this type of tests? Is there proficiency testing? These are some of the questions that would come up when we do point of care testing.
Mm-hmm.
So the other thing that we need to look at the point of care testing menu is how are the sensitivities and specificities for some of these tests, and how do they compare with correlation with the standard methods that we use in the laboratory. Correct. So these are some of the questions that would come up when we do point of care testing. So I'll just give you an example of point of care testing for SARS-CoV virus 2. Yeah. An article I read in one of the journals, Pathology, where we are doing point of care testing. You get your results in 20 to 30 minutes. But when you compare it with the NAT testing, so a positive test would correspond to a CT value of less than 25. So if you have a CT value of more than 25, then the point of care testing for SARS-CoV-2 with rapid testing will not pick it up. So these are some of the dilemmas that will come across when we do point of care testing. No doubt it has its usefulness, but there are also certain restrictions that have to be followed.
Very clear.
Yeah.
Very clear, very clear. Paresh, this is a nice outline you've given. Capacity building, I think everybody agrees with you, because if it's done in a very erratic manner, who's doing it, standards. I think in Africa, what I'm hearing from you is experts like yourself and others, we should be now moving to standards. So if we don't have standards and systems, we may throw out the point of care testing, which might be the best secret for household diagnostics and better health. So I think we have a responsibility as champions on the landscape. The second thing I'm also hearing from you is the quality standards. And I know Nigel, I'm going to come to Nigel later, when you talked about CT values and how accurately will these point of care pick antigen as compared to PCR. It's a concern. But Paresh, talk to me about costs, because you see many people, and I know you already find many people complaining about laboratory charges and costs. We have to move the needle towards more cost-effective testing. You also heard about CRP from Professor Theron. What's your view about costs, and then very briefly about CRP. Then I'll bring Esther onto the podium.
So if I look at the costs, yeah, if you're doing the cost per test, if you work out the cost per test, for the rapid testing, the point of care testing, the reagent or the strips or whatever we are using to determine results may be more expensive as compared to the conventional methods that we use in the laboratory. But when it comes to, I'll just give the example because this is the in thing right now, and that's where most of our work is. Testing for SARS-CoV-2 with the antigen testing appears to be cheaper than doing the PCR, only that the issues of sensitivity come about because of detecting antigens. The CT value would be more than 25. So you can't make a decision at that time. But and the thing that you have to consider for the nucleic acid testing by PCR is that you invest in equipment which is very expensive. It is labor intensive. It's a multi-step process, yeah, and you need qualified staff to do this testing, and you have to pay them well. So your overheads when you are doing the long testing, the PCR it turns out to be more expensive when compared to the point of care testing, and that's why it's more expensive for us to charge these patients as compared to the point of care testing. But it still has a useful role, point of care testing. For those who are positive, they want to confirm with a rapid PCR. Those who are negative can watch for a couple of days, and if they develop symptoms, they can come back for a PCR testing. That's the principle that we use. CRP testing is a very useful tool when you're suspecting infections of various types and when you're monitoring the patients. But I don't have much experience with point of care testing for CRP. But in practice, we would like to know the trend of the CRP value so that we know that the patients, whether they are responding to treatment or whether they're getting worse. Now, I don't know if point of care testing would address the issue of follow-up of patients.
True.
So that's one of my concerns with point of care testing for CRP.
Perfect.
Yeah.
Thanks. Thank you. And I've seen Dr. Bernard Fiku talking about CRP tends to wane in inflammatory TB. I've also seen some questions coming in, just wondering, should we use CRP instead of ESR? And I've seen questions from Mabengu about, oh yeah, good to be here, and Christine. Thanks, Paresh. I am going to keep you on the panel room. Please stay in. Let me now take the opportunity to invite Esther. Esther Segae, who is another leading champion in the diagnostic space from the University of Addis Ababa, is a hematologist and an immunologist. Esther is dialing in all the way from Ethiopia. I'm so delighted to welcome you on the podium, Esther. Tell us your views. You've always been a proponent of quality testing across Africa. You are one of the champions also when it came to making sure that PCR is being done in COVID appropriately. I'm delighted you've joined us. You've heard the conversations from Professor Theron, from Dr. Dave. What are your views about point of care testing? Where do we stand in promoting innovative testing in this continent? And you have your own experience about this. Please share with us your concerns. Please welcome Esther on the podium. Esther, over to you.
Okay, thank you, Dr. Amit, and the whole group for inviting me for this session. And could you please allow me to share? I have a few PowerPoint slides.
Of course you can.
Yeah.
You have about 7 to 8 minutes,
Yeah,
and then we'll go to the next panelist.
I will.
And then I'll bring back for the question. So please give Esther a chance to share the slide, the team. And I can hear you very clearly today from
yeah, you know, I'm not in my office because of the internet connection. You may see me on a corridor. Anyway, it doesn't matter.
But I can hear you. I can hear you very clearly. And I'm sure we are happy to, oh, perfect. I can now see you.
Maybe,
Try to share
could
your
you please
screen now.
enable me to share?
Yes, go ahead now.
Okay. Okay, I will.
And I'm sure you'll get the opportunity to try and share that. It's perfect.
Yes.
It has loaded.
Yeah. So it's a very good continuation of the previous speaker. Professor Teron and Dr. Dev have made my talk easier. So I will directly go to the challenge of point of care testing, as well as what should be done, as I was guided by you during the orientation. So I'll briefly start YPOC, maybe very brief, and what the hindering factors are and what could be done to effectively use them in Africa. So these are the barriers. Maybe I will directly go. Again, the challenge, the advantage of POC have already been done. It can be done by the non-lab personnel, minimal technical expertise, is the fast AT. All these are, in addition to this, even you can directly add the samples, which minimize one of the major pre-analytical error of specimen management. And also we can use either disposable devices or devices that can be easily maintained. Cost can be both as advantage as well as a disadvantage. I will come to it in a few minutes. And ultimately, by having this test, we will have patient satisfaction. Their applicability, I will not take you again. HIV, thank you, Professor Teron, you have shown us HIV, TB, all these are still our challenge in Africa, communicable diseases as well as non-communicable. I don't know in the other African countries, but if you come to Ethiopia, trauma is also one of our triple burden. So they can be applicable in, in many ways. But the major challenge is like by having distance being done near to the patients at multiple sites, we will have like a diverse group of testers which are involved. This makes for the central laboratory overseeing all these personnel difficult, and also documentation of the results, that is a post-analytical error could be introduced, as well as storing these devices, point of care test at these multiple sites could also be another challenge. I have said by involving the lab personnel, unless we do it with strict training and supervision, the testers could be not only with diverse background, their level. Some of them could be junior ones, others senior, nurses, sales officers, all sorts of medical personnel could be involved in this testing. So unless we do it with proper follow-up and guidance, supervision, this could be, challenging. Sorry if you have a background sound. As I said, to look for an internet connection, I'm in a corridor. I'm sorry. Sorry for that. So
no, it's going well.
By having
well done.
this,
carry on.
An error that could arise at a single site. We can imagine in the lab, we do have errors at the three phases, pre-analytic, analytic, and post-analytic. You can imagine when you do this test at multiple sites, we can amplify the errors. These are, and of course, having substandard point of care tests could also be a challenge in Africa. Again, the other challenge, there are several studies which have pointed out, stockouts are also a common challenge, quality assurance, safety, because we don't have a number of devices, unless we dispose them safely, that could also be a challenge for the healthcare service. Of course, cost per test, as I said earlier, it's also a challenge because sometimes having immunoassays, doing them in batch could be much less, they could have less cost when we see the overall patient care. The quick diagnostic and treatment. Sometimes, when physicians do not trust the point of care tests, they may ask for confirmatory testing, which makes the testing even more costly. The other challenge in Africa is interfacing these point of care devices. A very good example recently we do have with COVID testing using the rapid test. To interface the results, you need another hub, another connectivity. So these are also the major challenges. Internet connectivity, some of the devices need internet connectivity. That's also a challenge for Africa. From the patient perspective, through our experience, when you talk to the patients, they say they don't like this multiple finger pricking. That's also plus the patients, when they see the result being done with these small devices, some patients may not trust our result. So as I said earlier, there are a number of studies, but most of them have identified quality issue. Ensuring quality is a major challenge. Ensuring supplies is also the other challenge. When we see the combo, again, when we combine tests, I will come in a few minutes, even combining a test, we have to be careful so that cost is also affordable. What's displayed here is also an evidence which involves a study which involves more like about 140 low and middle income countries, where they found out common stockouts for the common pandemic in our area. So when we say what should be done, Dr. Amit, one of the one of the areas that I was asked to talk about was what should be done to curb these limitations. It has to be, I always say it has to be a need-based one, whatever solution that we are providing for Africa, it has to be a need-driven. And also we have to understand the diagnostic ecosystem very well. And combining more combo tests, again, we have to be careful which tests to combine. I have seen one of our audience asking a question of who is covering these costs. That's why we need to be selective of for which test do we really need the point of care testers. Standardization, again, with the previous speaker, I have also heard of standardization. We need to have a standardized point of care test, because we do have experience where when we do local evaluations, some of the point of care tests are really substandard. And also less complicated devices that can easily be interfaced with our laboratory information system. And also manufacturers and partners should think of capacity building. And I am a promoter because COVID has given us a very good lesson that local manufacturing, partnering with local African scientists and supporting not only the devices, the quality control materials locally, that will be the way forward, I would say, and also think of minimizing tests. In fact, I should leave what should be done from the user side. It's very clear, but there has to be, whenever we introduce point of care tests, quality, and safety is a major concern, and there has to be a strong supervision from the lab side. Maybe I heard from the previous speaker that whether we have, guidelines for point of care tests. For example, in Ethiopia, we do have a guideline for point of care tests, but the challenge, even if we do have the guideline, the challenges are still there. And of course, supervision, having the guidelines, the necessary SOPs, training of the non-laboratory professionals, and strengthening the supply management chain, and also thinking of these vertical programs. For example, we do have HIV program, TB program, and others, ANC programs. So there has to be an integration of all these programs to make use of the point of care testers with which do have combined testing capacity. So with this, I will summarize. Of course, we need in Africa, we need to scale up point of care testers. There are several challenges, including sustaining the supply chain and from the manufacturing side. It has to be driven as well as in collaboration with African scientists. And the POCs have to be standardized, easy to use, and with more cost reduction, more cost effective. I don't mean more cost, but more cost effective, because we say they're affordable. And of course, with strong supervision from the lab. People, when they shift the tasks, usually there is a disconnect between the lab and the point of care testers. Maybe it will come in the Q&A, we'll address that. And thank you so much, the audience, as well as the ABH team for the invitation. Maybe Dr. Amit, if I didn't finish my time, could I comment on the CRP and A?
Please do, because I want to hear your views about CRP.
Q&A session.
No, go ahead and comment on the CRP. Go ahead.
Yeah, CRP is, by the way, I used to work in hematology lab, and ESR is one of the oldest. And of course, we know it is the most non-specific test that we have. With one of my master's students, we were trying to see, to use CRP and ESR before admission, and my phone is disturbing me here. So sorry, before admission and at discharge of patients. Initially, we see most of the patients were having abnormal ESR. There was a concordance at admission. At admission, there was a concordance between the CRP and the ESR. But at discharge, there is so much discordancy. The CRP went down, whereas the ESR remained a little bit elevated. So from that, we proposed we can still use CRP in our study patients. We were using a diverse population, but we should, repeat that study by having, for example, only TB patients or patients with other inflammatory disorders. Otherwise, from that simple study, we have seen the CRP is really good to monitor, the patients.
Yeah.
Thank you. Thank you so much.
Thank you. Thank you, Esther. Thank you so much for this wonderful presentation. I think you could not have put it better on the challenges on the African continent and what we face. I also think it brings us nicely to the Lumira team. And I want to move quickly to Nigel Linden. Nigel, it's good to have you on the panel. I'm going to come back to Esther, Professor, and Paresh later. Nigel, we last met in Scotland, and I was very impressed with the work and the kind of innovation Lumira has done. I want to invite you on stage as the Chief Innovation Officer to tell us, you're speaking to the team in Africa. You've heard the conversation so far since the beginning of the webinar. Please speak to us, give us your comments, because we are eager to hear solutions. Welcome, Nigel, on the podium.
Thank you, Amit, and really nice to be here. Thank you for the invitation. And thanks to the speakers for some really interesting presentations. I'll pick up on a few points, and I'm sure it's exactly what you expect me to do. The first thing is to just think about point of care from a design point of view. If you design, if you look at the current products, which I think is where most of the comments are coming from in terms of their sensitivity and their performance, etc. I think it's because those products have really been designed to be low cost. at scale, and that's what you're getting. You know, if you have low cost products, then you're not getting the quality, you're not getting the sensitivity. I mean, you visited our labs and you know exactly how we view point of care. So as a company, Lumira DX was set up specifically to develop point of care diagnostics and specifically to develop a platform for point of care use. And therefore, we started with a blank sheet of paper to design a product that met all the demands of point of care. Very much centered on ease of use, an easy workflow. So real simplicity in how the product is used. And it's a platform designed for multiple assays, and each assay is exactly the same workflow. So as soon as you can operate one assay, you can operate all assays on our platform. And the intent is to have many tens of assays eventually. And not only is it simple, but because our product, and you can see it on the screen in front of you here, you can we present our data as a digital output. So there's no reading of lines, there's no confusion in terms of what the result is. It's a clear digital result at the end of the assay. So that's the first thing. Secondly, we've designed the platform to be accurate and high performance and very high sensitivity. And just to comment on what was mentioned about CTs and SARS-CoV-2, and that point of care tests can only measure to CT25, and that is probably more or less accurate. I'd say slightly higher for lateral flow tests, but for our test, and there's numerous, you can look at our own data, but there's also numerous independent evaluations of our test, and we see results, positive results up to CT33, and that's actually using COBAS 6800 as the comparator for that testing. And it's because of it's a microfluidic test. It's not a lateral flow test. It is an immunoassay, but we're measuring fluorescence. And because we're managing the assay on the instrument, we're able to get very high performance, very high sensitivity, coupled with specificity as well, and seeing the CTs of 33. What I'll also say in terms of managing disease and comparison to PCR, I mean, PCR absolutely, incredible sensitivity, but people need to remember PCR is measuring RNA. It's not necessarily measuring virus, it's measuring the presence of RNA. And there is a downside to that, because there is, you can get RNA lingering well after the infectivity has disappeared. And in fact, if you correlate PCR with antigen testing with viral culture, actually antigen testing correlates with viral culture very well, up to about up to about CT33, virus is culturable. And after that point, many believe that the actual infectivity is gone. There is remnant RNA and it's still measurable and can be measurable for weeks or months. So just bear that in mind. The different tests give you different information. All of it is valuable, but it has to be interpreted in the right way in order to make the right clinical diagnosis. So on our platform, we've designed it again for high sensitivity of the tests. Scale and cost are important. And Amit, you will have seen, we produce all of our assays on a single manufacturing line. So regardless of what that assay is, we take advantage of the scale of our system by producing everything on one manufacturing line, which means that we can produce millions of tests on that line, and we get the economy of that scale that we can pass on. So we can have a high quality product coming off a very well managed manufacturing line, where we measure key parameters to ensure quality. And we can do that to make sure that we can pass on or deliver product at very competitive cost. And also our system is designed with connectivity. And in Africa, and Mark Matthews, who's in Africa and has been at the center of deploying all of our system, he can comment on the effect that having connected instruments in the field and has had on the health system. I've already mentioned that our platform's designed for multiple assays. So we mentioned CRP. We have a CRP assay that we're just about to launch, which will be available in Africa on the platform. So anybody who has our platform in Africa will be able to run CRP on it. And we are also developing a TB test, molecular TB test as well, which will be eventually will be available in the coming months too. So we aim to have a full repertoire portfolio of tests, especially in the respiratory space, which is very pertinent to what Professor Theron was talking about.
Right.
And our system's portable as well. So getting our system and all the pluses of it to the patient to get accurate determination. So I hope that's answered your question. It's all about design. If you design it, the point of care system, to deliver the quality, deliver the performance, and deliver the low cost, it can be done. And that's what we've done.
Thanks, Nigel. And I think you've hit spot on. I think everybody's excited about the CRP. I'm just showing you on the screen, those who can see, this is the kind of strip that Nigel, I saw the Lumira team putting up there, just to show people. It's very innovative. I am really delighted. It's a multiple test platform. And this really leads nicely to Mark Matthews, who is the Business Development Director at Africa. Mark has got something to tell us on what's been happening on the African scene and share with us. By the way, the instruments are here in Africa, and I think the tests are here. So we've begun. Now what we need to do is, with all this fantastic thing Nigel has said, we need to add more tests. So it's not only COVID. Maybe COVID gave you the first ticket of Lumira to come to Africa, but then you are going to make sure it carries on. Mark, over to you. Tell us what's happening.
Thanks very much, Amit. So you're 100% correct. We do have a number of instruments in Africa. And I just need to thank Asta and the previous speaker for highlighting some of the challenges in Africa. These are the challenges that have been most important to us as an organization that we needed to address when we set out to deploy our instruments and tests into Africa. So I'll address some of that in my forthcoming slides. But just a quick overview of our African program that you referred to. We've had the privilege of supplying a number of instruments into Africa, largely funded by the Gates Foundation, Rockefeller Foundation, MasterCard Foundation, and with significant support and advocacy from the team at Africa CDC, both at a continent level and also regionally, and then through the Africa Medical Supply Platform. So, that's enabled the program. And 7 months into the program, we now have 5,000 instruments into 49 countries. So that's 90% coverage of the African Union. So Amit, you're 100% correct. We do have these instruments in Africa in those 49 countries. And of those 49 countries, 37 countries have completed their implementation now and are actively testing using our SARS-CoV-2 antigen test that Nigel referred to. And then the balance of the countries are in various stages of implementation, and we'll have those countries actively testing before the end of this month. So there's been a lot of discussion around the standardization of quality testing. Obviously, the test that we have has global emergency use from the FDA, and we're in the final stages of EUL with the WHO. But we've also been extensively validated in 23 countries. And I have to say that of all of those 23 countries, we've come out with very good lab evaluation and field validation reports. And those are the 23 countries that have requested validations. And then we formally registered in 22 countries. So, that speaks to the quality of the instruments and the test. And I suppose differentiates the instrument-based technology that Nigel was referring to the other points of care technology in the market. And then, we hear time and time again, and it's been mentioned by one of our previous speakers, the competency of the end user is critically important in a point of care device or point of care technology. So we've managed to train our Ministry of Health end users in 39 countries, both directly and face-to-face training where permitted, but then also through our learning management system, which is a remote training facility. And then we have more than now 50% of our instruments connected. We've heard the importance of having connected technology in Africa. It's important to note that we have more than 50% of our instruments connected, and that number will grow over the next couple of months. And then I suppose the technology itself has provoked a high level of innovation in terms of the testing strategies and deployment strategies in our ministries of health. And we see a number of innovative testing models and use cases across Africa. You know, we heard from Professor Grant-Turon about the need to decentralize care, get it closer to the patient, and we've seen evidence of this in the COVID program. So we have our tests in level 1, level 2 primary care facilities, which is really the sweet spot for our technology. We have testing in district hospitals and border crossings, in ports of entry. A number of airports are using our tests for passengers arriving in country. We have targeted mobile field testing enabled by our technology to find out where the high risk areas are. And then we have some testing in government institutions for occupational health testing and testing in schools. So a good example of the coverage of the level of utility of technology, of our technology in Africa. Next slide, please. So when we speak about the program that I've just referred to, the tests that we've supplied are our SARS-CoV-2 antigen test, which is in the middle of this slide. But it's important to note that different countries are at different stages of the pandemic and require different diagnostic tools. And this is the value of having a multi-assay platform, not just for other diseases, but also for COVID. So we have the antigen test that I've just referred to. We also have an antibody test, very important as countries start their vaccine rollouts, and there's a lot of vaccine decision-making that needs to happen at population level and at patient level. And then as we hopefully cycle out of the high prevalence periods, we have an antigen pool test that enables 5 tests to be done at the same time. And this is suited to high throughput testing. And then for the laboratory people on the call, we have a molecular kit called RNA Star Complete, which is able to be run on the open molecular systems across Africa. So a good basket of COVID products suited to the different stages in the pandemic in different countries. But certainly targeted to decentralize care and get it closer to the patient. So next slide, please. So obviously, as we hopefully are moving away from just focusing, we heard from Professor Grant-Turon the need to return to our high burden diseases in Africa. There's no better example of that than seeing the 30 to 40% drop in TB diagnosis in our high burden countries in Africa, and the need to return or reallocate resources and focus to addressing those high burden needs. And we've understood that as an organization. So we have a robust pipeline over the next 12 months to deliver the tests that you see on this slide. We've obviously mentioned the antigen, antibody, and pooling test, but we also have an INR test and a D-dimer test, which is currently launched into the African markets and in various stages of registration and validation in some of our African countries. D-dimer important for its more formal coagulation and cardiovascular diagnostic use, but also as a prognostic biomarker for COVID. And then, to our previous speaker's point around the respiratory pathway and the importance of that, and also the polymicrobial aspects of the respiratory pathway and the need to diagnose not just TB or COVID, but other pathogens. We have a number of tests coming out, which are well suited to the respiratory pathway. So we have a flu test. We have the CRP test that has been in hot discussion on this call. That's coming out in Q3, and it goes straight into a study for its use in the TB pathway. We have an RSV test, not combined with flu in this slide, but with COVID. And then we have a number of other tests. We have a troponin test, and interestingly, TB and HIV molecular assays with a level of near-term prioritization on the TB assay, because we need to get our TB patients back in clinics and diagnosed. So a robust pipeline addressing not just COVID, but a number of different diseases, and really exemplifying the polyvalent multi-assay capabilities of this technology. And our encouragement to our ministries of health decision makers is to start utilizing this polyvalent technology. So next slide, please. We heard from Professor Grant-Turon how we're asking our key decision makers and our clinicians and policy makers in Africa to reimagine the respiratory pathway. Similarly, we're asking our Ministry of Health key decision makers in Africa to reimagine what the primary healthcare model could look like in Africa. And this is largely enabled by a platform that can do both communicable and non-communicable disease testing. And we heard from Nigel, and it's been a topic of discussion on today's call about the affordability of testing. And that's a significant priority for us to enable adoption at scale. That's very important. The portability of our instruments and the ease of use allows it to be moved closer to the patient. And, obviously with the 12-minute test for our technology, we enable a same visit result. So earlier diagnosis and the linking of that patient to treatment enables fewer clinic visits, and the ease of use that we heard enables the task shifting to a lower skill set end user, which enables it to be used in a decentralized primary healthcare environment. And then our connectivity enables both the instrument's test result to be sent into a health information system. And remember, it's not just about providing more testing in Africa, it's about getting more test results back into the health system and back to the patient. So our connectivity plays a very important role in that, and also enables that test result to go into a longitudinal health record and to enable the formation of an electronic health record. This obviously improves the understanding of health conditions, both at population level and at patient level. And then as we decentralize care into remote primary care environments, the connectivity enables remote clinical support. Next slide, please. And I only have a few more slides, Amit. I won't be long. So what we've encountered in our last 7 months of this program as challenges, not specifically only to our technology, but to point of care technology in general, is that there is a risk of having end users of point of care technology that are inadequately trained. At the beginning of the pandemic, we saw proliferation of counterfeit tests in the market, counterfeit antigen tests and antibody tests. And there's always a risk of tests being used beyond the expiry date. For visually read lateral flow tests, there's the risk of interpreting the test result incorrectly, where data is taken manually. There is a risk of patient misidentification, and then quality controls that are performed in certain countries and environments aren't adequately adhered to. And then obviously with the portability of these instruments and the fact that they often moved from facility to facility or district to district, there's always a challenge in keeping track of these instruments and tests and also their utilization. So next slide, please. So how have we addressed this as an organization? Because we have an instrument-based technology and because we have connectivity, we've been able to address a number of these challenges. And these are challenges that have also been referred to by some of our previous speakers. As part of our training, we certify the competency of our trained end users. They are given a username and password. These login credentials are then used for the end user to be able to log into the instrument. And only trained end users that have these login credentials can use the instrument. This largely prevents under-trained or incompetent end users from using the technology. And then once they're on the technology, they have step-by-step guidance on how to use the test. And I think really what is required before we even run the test is that the patient details need to be logged into the instrument, which means that the patient test result is linked to the details, the patient details, so preventing patient details from getting mixed up. And then we have a 2D barcode on our strip, which creates the automatic detection of the test type and prevents expired tests or counterfeit tests from being used. And then Nigel referred to that clear result that is displayed on our instruments test window, preventing any misinterpretation of test results. And then we have an interesting level of utility in terms of the fact that we have quality control alerts, and that can be logged into the instrument. That obviously enables both end users and instruments to be locked out if those quality control protocols haven't been adhered to. So inbuilt quality controls that are monitored through our connectivity that largely addresses a lot of the quality oversight concerns that were referenced by our previous speakers. Next slide, please. And this is my last slide. And I'm taking a step away from the technology now and looking at this from a programmatic perspective. We've understood that while our technology is one part of the solution, the programs that develop around our technology are critically important. So we've understood that as we decentralize diagnostics into primary healthcare facilities, the linkage to care is absolutely essential. And this means that clinical decision-making capacity and the availability of treatment and therapeutics in those environments is very important. And in the absence of those 2 points, we'd need to have an effective referral system. We've made mention in previous discussions on the need for quality control and the implementation of EQA programs. We have good quality oversight of our technology, and we also support a number of EQA programs. In terms of the supply chain control, this is absolutely essential to prevent stockouts, especially in decentralized settings. And having connectivity and an instrument-based test makes that easy to mitigate. Most importantly, Amit, there is a need for Ministry of Health ownership and country-level ownership, both of the implementation process and of the program and its ongoing support. And we see this as a responsibility of the manufacturer to enable a level of skill transfer to the Ministry of Health and to the country. And this is also a role of the implementing partner. And this brings about the need for capacity building in country through training and learnership programs. It's something that we are very much in support of, and also developing a high level of proficiency at various levels of the health system, all engineered to create sustainable programs that are able to absorb and adopt and absorb these new technologies that are coming into their primary healthcare systems that will enable the kind of impact and outcomes that we expect from this technology. So Amit, back to you. We think we'll have an interesting Q&A session after this.
No, this is great. This is amazing. You've got so many fans from your presentation. You've got Nonye, Jacob Okoth. I think what's really come out is you've created technology to keep standards. So there will not be erratic things happening. I think that's what someone says, beautiful. So I think I echo those words. The other thing you're saying is, let's build capacity, because this is the future. And this is what Paresh was saying and Esther was saying. If we build step by step, 5 years, 10 years, the next generation will remember what we did, and they will have a better diagnostic system. So, you know, time always runs out, but you've laid it out so well. I want to take just a few minutes and ask Greg to say a few words in 2-3 minutes. After that, I will, and I want to thank Professor and all the panelists who are answering the questions. Let's do that simultaneously. We may not be able to do too much Q&A, and I'll come around and give everybody a minute of parting shots and announce what we're going to do next. Greg, over to you.
Thanks, Amit. And it literally takes a minute or two for me to make my point. When we talk about connectivity and connecting devices, especially as manufacturers, we often refer to connectivity at the device level. And we as manufacturers, as users of the technology and at the MOH, need to start asking ourselves new questions about that and challenging ourselves to think beyond that level of connectivity. We need to move beyond just connecting instruments, and we need to start focusing on connecting clinics. We need to have, and patients deserve, a health record that accurately reflects the full clinical picture and history of that patient. When we deploy connectivity, it should be absolutely seamless. It should integrate into the national health system, and it should provide all the users of that data the access and the information that they need as simply as what they need. And that connectivity should be a reflection not only of the health of the population, but the performance of the health system itself. We've seen lots of concerns raised over things like users not being trained properly, EQA and quality assurance, and all of these things. That all ties together with connectivity, and we should focus on that as a means of bringing quality to point of care testing. Connectivity should work with minimal effort on the part of the user. They should not have to struggle to get their devices to work, and it should create minimal administrative and support burden, technical burden, for the resources within the Ministry of Health that are actually looking after those systems. And it should present data in a manner that is accessible, relevant, and above all secure. And connectivity should work at all levels of the health system. And the next generation of point of care devices that that we are looking at bringing to market, these should be polyvalent devices, and they should meet all of these connectivity criteria. And that's what we're working to with our connectivity solution. So thank you, Amit. Back to you.
Thank you, Greg. And being the training and technical services lead, you really hit the nail on the head about connectivity. I'm going to invite you guys to different African countries. And I know Lumira has been really busy. Nigel, we're going to invite you to Africa. We're going to give you an invitation. Many people here want to meet you. Mark, we want you to travel if you can, and Greg. But what you've shared with us is extremely exciting, and I'm hoping we soon start getting new tests coming up. Greg, could you answer one question? It's an elephant in the room. What's the test going to cost? A COVID test, typically, when you do an antigen test, can you give us a range in US dollars terms?
So these tests are currently available at a subsidized price of around $2.70 through the AMSP platform.
That is amazing. So maybe Paresh and Esther, you saw those numbers of $2 to the, when it's not subsidized and it might be full price, will it move to like $5, $6, $7, $10, something like that?
You want me to answer that, Greg?
Yeah, Mark,
go ahead. Go for it, Mark.
Yeah, so we have a subsidized grant from our funders, Amit, to enable scaled up testing, as Greg mentioned, at $2.70 a test. And we have, I think, 1.5 million tests for Africa at that price. After that, it goes up to $4, just over $4 a test.
Fantastic. I tell you, Sissy, you've got your answer. Even if it's $5 or $10 or whatever it is, at the moment, households are being hit left, right, and center, and it's really belting them. And they are paying $50, $80, $90. So I'm enjoying these numbers. And Paresh, your hand is up. Can you comment on that? What do you think?
Yeah. So how much does the analyzer cost?
Oh yeah, good point. What does the equipment cost, Mark?
Yeah. Thanks for the question. Paresh, we've got 5,000 instruments over, our install base is 5,000 instruments in 49 countries. If there's an increased need for instruments, we have the instrument available through AMSP at $4,000 an instrument.
How much is a PCR machine, Paresh?
We spent $7 million to get ours.
Which is how many dollars for the people who are here?
$70,000.
$70,000.
Yeah. What's the throughput for this machine? How many PCRs can we do, say, in 1 hour?
The test time is 12 minutes. And then if you remember, I spoke about the pooled test. The pooled test can do 5 tests in 12 minutes at a time.
And what's the principle of testing? Sorry.
Explain your question, please, Paresh.
I wanted to find out about the principle of testing. What's the test principle?
Amit, maybe I can take that discussion offline.
Yeah,
with
go
Paresh.
ahead. You should take it offline with Paresh about whether it's the protein testing, immunoassay. So Paresh, these are getting
so I can quickly say the SARS-CoV-2 test is an antigen test and it uses immunofluorescence.
There you go.
Okay.
And these experts who are going to get really more technical, you guys, the idea about this webinar was to have an excitement and offline conversation. Let's not stop. The people who are attending and on the panel, listen, Lumira is here. And Lumira is here to make an impact in Africa. I think that was the purpose of this webinar. And we have many more sessions coming up. And we have roundtables. We've invited Lumira to also have in person in Nairobi a stand and a presence in February. I'm going to tell you more about it a bit later, but I want to move to the parting shots to these super panelists that we have, and I'm going to give them a minute each. I know we are coming close to the stop. Let me start with Paresh. Let us have your parting shots, Esther, and I'll come to Professor Theron. We'll answer your questions. Those which haven't, we'll come back to you. Paresh, over to you.
Yeah, thank you. It was interesting to hear about Lumira, and I look forward to seeing you in February. I'd like to have a first-hand experience with your analyzer. If I may ask just one more question, sorry. You mentioned we can do antibody testing as well with the Lumira. Is it able to tell us whether it's IgG or IgM?
No, the current assay is a total antibody test.
Okay, thank
And
you.
it's aimed at the S1 and the RBD antigens.
Okay. Thank you.
You got your answer. They will meet you in February. Esther, over to you for your last parting shot.
Okay, thank you, Dr. Amit, and also for being here with these great presenters as well as audience. I really enjoyed from the presentations from Lumina and also the comments from the audience.
Thank you so much for your.
Maybe my last message is for any manufacturers. For example, one of the comments here is about corruption of during procurement of kits and supplies. So when you bring a solution with better QC, better patient information access, better, password control, everything, I understand the cost will be higher. And other substandard devices could be cheaper. In Africa, specifically, I could tell you in Ethiopia, we go for list price. So in that case, if you also train the lab managers and those who forecast, those who made the specification, then at that step, it's possible to exclude those substandard devices. Otherwise, if we compare prices, we always go for cheaper. And as much as possible, try to go to lower the price and also to have this North-South collaboration and go for partnership and making the production locally. Maybe other than this, thank you so much. Thank you all. Hope we could meet later.
Where there's a giver, there's a taker. It takes two to tango for corruption. But if we gave nothing to no one, but it's another webinar. I totally agree. We need to root out that. Professor Grant Theron, we learned so much from you. You taught us new insights. Thanks for sharing that presentation. Could you give us your parting shots?
Sure, thank you, Chair. I think my most important parting shot is really to ask that we treat respiratory diseases other than COVID with the same intensity that we treated COVID. We have forgotten that there are actually public health emergencies that in some ways are more severe and more long-term than COVID. And I think if we apply that same energy, especially with diagnostics and the respiratory pathway, we can reverse some of these diseases that have been with us for hundreds of years, not just 18 months. Thank you.
Thank you so much. Thank you, everyone. I'll also give you a thumbs up, Professor Grant, for being so cool at answering the questions on the chat. Keep it up. Great to have panelists like that who are interactive. Let's move on to the closing remarks. Next slide. My closing remarks is to thank everyone. Mark, it's been a pleasure working with your team. It's been truly amazing. We've got great panelists. Thank you for your time. On the next slide, you will see the February we were talking about. Save the date. I'm trying to convince the Lumira team to have an actual booth here. We will be celebrating and talking about Africa Women's Health Day. We have ministries from different parts of the world. I know travel will be a problem. Those of you who cannot travel, there will be a link and you can join us at the hybrid session. The logging in for this session for 1 day is free of charge. There is a ticket entry fee for those who will be in Nairobi, but I welcome you all. With those few remarks, I want to thank the team at Lumira. I want to thank the team at AHB. I want to thank the attendees. Without you, we wouldn't be able to discuss so much detail that we went into. And all of you who posted questions, you made it even more exciting. Thank you. Bye for now, everyone. Have a great evening.
Thank you, Amit.
Thank you.
all.
Pleasure. Thank you very much.
Thank you and goodbye.